now we will be starting our discussion of the day. So first of all, let us have another look at the acanthocytes.
Order பண்ணிட்டீங்களா? இங்க நோட்டிஃபிகேஷன் வந்து வந்துட்டல.
Okay. So first of all, look at the acanthocytes. And when acanthocytes are basically present, acanthocytes, there you can find the spicules on RBC. And the reason why spicules are found, because the RBC lipid membrane is unstable in certain diseases, which will lead to acanthocytes. Either there are certain physical insult or there are certain chemical insult. So acanthocytosis is basically seen in splenectomy, post-splenectomy status, in alcoholic liver disease, in A-beta lipoproteinemia, and hereditary spherocytosis. That is also basically a membrane disorder. So these are the major areas where acanthocytes are present. Why these things you need to know, or how these things you need to know, and what is the difference from MRCP part 1 from your pathology things. You do not need to remember a lot of things over here. All these pictures, there will be no picture. First of all, remember, part 1 is a sound-based exam, word-based exam. There will be no pictures. So even though you are having a picture of this, basically you have to remember the words for the part 1. Slide like this will come in part 2. So just by remembering the picture won't help you completely. You need to know the particular terminology and keywords. Part 1 is completely based on keywords. And they will give you certain clinical condition along with, can you mute on that side? Slight noises are coming actually. Yeah, so they will give you a clinical condition where patient will have every features along with the peripheral blood features. So on peripheral blood features, the keywords you need to remember. Occasionally they may say RBC with spicules. So then acanthocytes or bar cells, you see, larger spicules on acanthocytes, smaller spicules on bar cells. This you need to remember. So on the basis of that, you have to answer. Now we are moving to two important concepts. One is anisocytosis, another is poikilocytosis. What are they? Anisocytosis is the variable size of RBC. Poikilocytosis is the variable shape of RBC. Once again, anisocytosis is an isocytosis. So RBC's size, iso, that means similar, that is an iso, that is broken down. So variable size of RBC. Poikilocytosis is the P for P. Poikilocytosis is for shape. So shape variation. So mostly they go hand in hand, and in IDA and thalassemia, iron deficiency anemia and thalassemia, anisocytosis and poikilocytosis are mostly seen. However, in megaloblastic anemia or bimorphic anemia, anisocytosis is seen, whereas poikilocytosis is more common in myelofibrosis because bone marrows are dysfunctional in that cases. We are again looking at the basophilic stippling. Look at the picture once, and now we are moving back to the basophilic stippling nodes. So what is basophilic stippling? What causes the stipples? These are the denatured RNA. How denatured RNAs are found? Denatured RNA are either formed due to defective hemoglobin synthesis or due to accelerated erythropoiesis. These are the two conditions only. Either defective hemoglobin synthesis or accelerated erythropoiesis. Defective synthesis may be due to certain disease, may be due to deficiency, may be due to infiltration, and accelerated erythropoiesis will be due to increased demand. Now let us look at the causes. It may happen in lead poisoning, very common. We know it since our second year. Hepatic disease, myelodysplasia, hemoglobinopathy, thalassemia, remember this one and remember this one, and megaloblastic anemia. So these are the cases where basophilic stipplings are present. In case the patient appears to be working in a factory, to be working with insecticide, or to be working in coloring industry, then lead poisoning or heavy metal poisoning can be one of the major reasons. Moving to the blasts. So blasts are basically nucleated precursors. So either they are found in various types of malignancy or marrow infiltration. However, that is not very objective over here. Moving to Barr cells, already we have seen the Barr cells. Once again, look at the Barr cells. Barr cells, Barr cells. Okay, so these are the smaller, this kind of a younger brother to acanthocytes. So Barr cells are RBC projections. Those are less marked than acanthocytes. May be found in case of acanthocytosis itself, also can be found in CKD. Now moving up, what is Cabot ring? So Cabot ring you have just seen over here. So basically that's a deposition and it's a ring formation by hemosiderin, which is found in sepsis, which can be found in pernicious anemia. Remember, it can be found in pernicious anemia and it can also be found in lead poisoning. Again, remember, if Cabot and this basophilic stippling both are present over there, it definitely goes towards the, lead poisoning. But Cabot rings are present and the patient is having hypothyroidism, just this much if it is there, then you think of pernicious anemia. Once again, the condition in MRCP exam, one very important premonition on which they work, that is, if there is one autoimmune disease, there will be multiple autoimmune disease or chances of multiple autoimmune disease. So if you don't get enough clue, think in this particular pathway that if you find a particular autoimmune disease in the person, so there's a high chance that another autoimmune disease. So there might be vitiligo. The patient may have type 1 diabetes. Maybe this much only clue be there, and with the help of that, you have to understand. So Cabot ring is present with vitiligo. Always think pernicious anemia as a very strong DD. Remember, once again, let me pressurize on it again. MRCP part 1, part 2, they always specialize on the fact that if one autoimmune disease is present, there is high chance of another autoimmune disease to be present in body. Type 1 diabetes, vitiligo, alopecia areata, any connective tissue disorder, hypothyroidism, pernicious anemia, all these are connected as per them. Okay. Now, dimorphic picture, what is the dimorphic picture? Basically, two different morphology of RBCs are present. There may be microcytes present. There may be macrocytes also present in the same smear. So how that can happen? That can happen due to partial treatment. That can happen due to both iron and vitamin B12 and folate deficiency. That can happen just after the blood transfusion. That can happen in primary sideroblastic anemia. So these are the places where we can find them. What is Hubble-Jolly bodies? Look at them. These are the Hubble-Jolly bodies. You see this one. Okay, so Hubble-Jolly body, one very important thing, where it is different, that it has DNA remnant. It's not the RNA remnant. It's the DNA remnant. So it is present. It can be present in normal physiology. In Hubble-Jolly body, it's present basically after splenectomy, or it can be present in hyposplenism. So normally what happens, spleen always removes, that's a sequestration. Spleen always removes whichever RBC is denatured or defective or having the DNA remnant in them. But post splenectomy, these are not being removed by the reticuloendothelial system, so they are present in the peripheral blood smear. So seen in post splenectomy, hyposplenism, and all the factors, all the diseases which are connected to hyposplenism, like sickle cell, like celiac disease, like ulcerative colitis, Crohn's disease, myeloproliferative and disorders, and amyloidosis. Everywhere it can be found, Hubble-Jolly bodies. Now we are moving to the leukoerythroblastic film. What is that? So basically, a lot of immature cells are present in this, along with teardrop RBCs. So Immature cells like the blast cells, the myelocyte, metamyelocyte, promyelocyte, normoblast, megakaryocytes, all these are present along with the teardrop herbaceous. When we can find them, we can find a leukoerythroblastic film in case of massive hemolysis, in case of massive blood transfusion, in case of malignancy, in case of marrow infiltration, in severe sepsis. So these are the places where we can find leukoerythroblastic film.